Good afternoon. As mentioned, I'm Bart van Acker, working at the Radboud University Medical Center in Nijmegen, which is located 70 kilometers from Eindhoven, northeast. And as I'm an engineer educated as well, I love complexity. And in our hospital, we have a lot of complex processes. So therefore, I love my work. And in our hospital, we have our own consultant department, which is named Process Improvement and Innovation. And we support our doctors and nurses to improve their processes on behalf of the patients. And therefore, we use a lot of data which they gather, and which is quite a lot and hard to manage. As you can see, that often happens. But this afternoon, this coming up 20 minutes, I will show you the difference between process improvement with and without process mining in order to explain the added value of process mining. But first, I want to talk about the strategy of our hospital. I will tell a bit about the management information we have in healthcare and we are using. And then the difference of process improvement with process mining, and on the other hand, process improvement with process mining. And at the end, I will briefly give two examples, one of an intensive care unit and one of a chair cane or pathway, the head and neck oncology. First, our strategy. Radboud would like to have a significant impact on healthcare. And we do it, and that is very important, because we all know health is very important in life. We have therefore 4 points: excellent quality, participatory and personalized healthcare, operation of excellence, and sustainable networks. We don't treat our patients just by their own. We do it in our network with the general practitioners, nurse homes, and many other hospitals. Management information in healthcare. We have management information in healthcare. There are only two tastes. We have either do it financially or quality. We don't have, we have only a very, very little about information regarding processes, like volume and efficiency. So production rates or throughput times and utilizations. We have only a very little of that information available. And 1.5 years ago, we have implemented our new electronic medical report, Epic. It's an American system. And it's the same problem. They don't give that management information. So we have to export data out of Epic in our own databases and use our own definitions. And these process informations are related to either a single step, like an operation room, a clinic, or outpatient clinic, or they are regarded to a flow. Like a chair cane, like head and neck oncology. I will deal with them both with my examples. But what are the consequences of a lack of information? We don't have any common objective view of our process. If you ask 5 frontliners, like doctors or nurses, to draw their own process, and you will match them, it's often that there are many, many differences. And then you also know that the failure rate will be above 20%. So we already know that the process in our hospital are quite complex. But by recovering these failures, it's getting even more complex. And if you have cancer as a patient, you won't speak just with one doctor. You will speak with several doctors and nurses. So that makes it even more complex. And that we see if we are drawing our processes with lean techniques like value stream mapping. There we see it, if frontliners describe their own processes. But it's what is quite interesting, it's often if we organize such a meeting, it's often the first time they talk with each other with that about the processes. And it's always based on experience, not on facts. And if I am asked to analyze such a process based on these assumptions, the results aren't always recognized. Say that's impossible. That can't be the truth. But they don't have any. But as we don't have any management information about processes, they don't have any experience in those results. So that makes it even more complex. And then afterwards, well, if they don't recognize these results, we have to validate it by picking out specific individual patient files. And then we see all kinds of exceptions. It's always different. Well, this patient was treated somewhere else, or it was a very difficult patient. And then we adjust the assumptions and start all over again. And after 1 or 2 weeks, I'm coming back with my new calculations, and we are doing the same problems. Still no recognizing the results, adjusting the assumptions. And then you're losing time, losing confidence, because they don't recognize the results, and you're losing momentum. It's a bit like this picture, where I'm considering, by using Excel, making the miracle happen. But it would be nice how does the process really looks like. And I'm asking not only what's happening here in my calculation, but I'm very interested, what is the real process? And then process mind can make the difference. You get a common and objective view of the process, which is based on facts. And based on that picture, you can really make a focus, as Joris mentioned, and pick the real goal, which is where you want to improve. Which part of the flow, which process step is involved. And then by the specific analysis by nesting and by process mining, using the filters amongst others, and you are winning time, winning confidence, seeing is believing, to really see what's going on in the process, and you are winning momentum. As I've mentioned, we have a lot of data. But this data will need to be processed. Otherwise, you will see more like a cobweb than a bird's eye view of the process. And if you are doing an analysis on one modality, like an operation room or an outpatient clinic, mostly one database is available. Well, you can manage with only one database. But if you want to analyze a chair cane, there are very different databases you have to get information out of it. And of course, the famous list of the doctors themselves. That's what you really trust, their own list of the patients which need to be involved in my analysis. And it makes, but the data we have is not ready for use. Many proceedings don't have any timestamp yet. They only have a date. And many proceedings are medically different, but regards to the process, they are equal. So as Mieke also mentioned, we skip the details, we build the proceedings, which are equally process-wise. If a proceeding is regarding an operation, let's call it just an operation. Or if it's dealing with chemo, I'm not interested in the difference between those chemo, I just call it a chemotherapy. So you bundle them. And then you're trying to sort, to create flow, because if proceedings have the same date, I don't know which one was first. But we know, well, if you first have your consultation with a doctor and afterwards the diagnostic activities, well, I sort it that way. Now we'll show you two examples. One of our intensive care unit, and our doctors and nurses, well, they always ask the same questions. It's about volume, throughput times, and in this time, translocations from 2 different intensive care units. We have, in this case, we have 5 intensive care units. 3 on the 3rd level, 1 on the 1st level, and you want to know about some translocations, especially from this one to that one, because say 3A is closed during weekends. And they were asking about these translocations and about the flows, and think, how can I manage that in Excel? And that will be quite complicated. But now we are using process mining. It was quite easy. So you could easily tell how many there were. And we're also very interested in these loops, because that was also regarded as a problem by the nurses. And these people shortly leave the IC for some diagnostics. They go for MRI or CT scan, and then they return. So we also saw, well, that that's about 183 people. And if you see the throughput times, you know, well, they are back within 2 hours. So it's quite easy to answer this question by using process mining instead of just Excel. The other example is the head and neck care chain. And we are dealing with above 10 years. And this is an example of how they describe such a process. And you see here the general steps which each chain usually have. With the sign up and the diagnostics and the treatment. And if you put these data into process mining, you see here the process, but I will go into any detail. But the more you pull out this slide, the more you see it isn't a linear process as described. It's much more complicated. But that makes it quite easy to say, well, what's really important? And as we can say, what's your goal? Our goal is especially the throughput time from the multiple disciplinary consultant till the first treatment, which is either radiotherapy or an operation. So what's the added value of process mining? Process mining, with process mining we can the real process is visualized. So the many trouble starts with the huge difference between what they describe and what it really looks like, and that generates a lot of confusion. And this objective image enables to talk about the same problems. What is really going on? And then based on the goal, which patient flow is important? Which part of the chain is really important, as I saw in the previous slide? And that helps us to create added value regarding our strategy. Excellent quality, operation of excellent, but also with the networks, if we use other data from other hospitals, and take the patient into account. Are there any questions?
And actually, so we have about 5 minutes time for questions, then we have a coffee break. And so Mika had started a little bit later with her talk, so you can also, I think you can ask questions to both of the last 2 speakers. But while you think about it, I have one question first for you, Bart. And one thing that I heard in the healthcare domain, which is quite a challenge if you're doing process improvement, is that, well, you have the people who are looking into processes, right, or quality people, but then you have the doctors who are performing the steps, and that it's quite challenging from a cultural perspective to get those people to participate. Can you tell a little bit about that from your experience?
Yes. Well, we don't start to saying efficiency as the goal. It's always quality, and efficiency will follow. That is not a real problem. But it's a problem is often that the doctors are very interested in very specific patients. As we are a universal hospital, they are always interested in the most complicated patients. But that are not the patients which have a lot of volume. So that makes it difficult if you are taking a general patient group with a lot of volume. They aren't interested to improve it, but they are well interested to improve the more complicated patients. So that is always a difference, difficult to get a right balance. But the goal is quality.
Yes, okay, thank you. Any more questions? Yes.
Hello, thank you very much for your presentation. Just a question, I don't know if you are aware, but your hospital earned stage 7 of the HIMSS this year. Has this significated a difference for this kind of projects?
Yes. Yes. As I mentioned, we also have our new electronic medical report system, Epic. And the databases are better structured than before. That makes it much more easier than before we had Epic. So therefore, I see a great improvement. But now we are only using process money for half a year now. And but we see, well, some questions can be asked, can be answered quite easily and quite fast. But especially in those chains, there it's quite complicated.
Thanks.